Ladies and gentlemen, it's a pleasure to welcome you to this opening of the 18th World Rural Health Conference, and I'll be absolutely delighted to hand you over to Innocent Basiji, who will, ladies and gentlemen, it's a pleasure to welcome you to this opening of the 18th World Rural Health Conference, and I'll be absolutely delighted to hand you over to Innocent Basiji. Over to you, Innocent.
Yes, thank you very much, Professor Bruce. I am Innocent Basije. I am a family physician, and I am the General Secretary for the Association of the Family Physicians of Uganda. But I will also be the convener for this event or this conference. A welcome to you all, our attendees. Good morning, good afternoon, and good evening. Allow me to thank you all and welcome you to this occasion, which is the opening ceremony for the 18th Wonca Rural Health Conference that is organized by the Wonca Working Party on Rural Practice in collaboration with World Health Organization, and is being hosted by the Association of the Family Physicians of Uganda. We should acknowledge that these are hard times where many people are going through stressful situations because of the COVID-19 crisis, which has really affected all of us around the globe. And I don't think any one of us has been spared. For example, here in Uganda, where we are under total lockdown, and we don't even know when it will end. With some of our colleagues, the doctors, the family physicians, and other specialists are battling the disease. And that is the reason why we are attending this event online. All of us are in isolation in one way or another, even those of us who may be seated in the same building, but we are socially and physically distanced in a way that we maintain the safety of each one of us. And I guess really many of us miss being together. We miss the hugs, we miss exchanging the business cards. We miss catching up with all the friends physically and sharing all the stories. When I was reflecting on what we are doing now, I said, what can I do? And that is why, if you notice, I am using a virtual background, which is actually a picture I took from my birthplace in the southwestern part of Uganda in the Kigezi Hills, which is not far from where people do gorilla tracking between the Democratic Republic of Congo, Rwanda, and Uganda. And I said, I needed to show my colleagues all around the world probably what they are missing, but you must keep hope alive that one day, one time, we shall be able to get together again. I know we would have loved really to have you here to physically experience Uganda, and also have the opportunity to probably travel around the country and appreciate rural health care. And maybe learn one thing or two from us, which one can take back to wherever they came from for making things better, or learning how to solve certain problems better, particularly those problems pertinent to the low and middle income countries, where we have where we provide rural health care amidst limited resources. However, we should always be thankful to technology that we are even able to meet amidst the circumstances. And allow me to let you know that we are still hopeful that one day, one time, we shall meet physically again and catch up. This will be a purely online event, which will be consisting of a series of webinars spread across several months. And we are borrowing from what our colleagues in Bangladesh did for the 18th Wonca Rural Health Conference. And we are hoping that you will always join us every time a webinar is advertised. We did not charge any registration fees because we are aware of the circumstances that each one of us is facing. And sometimes it is quite unusual that you will not even see this conference having a specific website. But we decided to really use the available channels, email, social media, various forms of social media to reach all of you colleagues around the world. And we are happy that at least we have managed to reach to almost all of you. And maybe this is the time to learn new things. Who knows? And in the interest of time, allow me to really thank Professor Bruce Chatter, the chairperson of the Wonca Working Party on Rural Practice, for reaching out to WHO and making sure that everything works. But also for entrusting us to host this online conference. You know, we are all running and we shall continue running together. And they also allow me to thank the speakers, those of us who will be speaking today, but also those who will be speaking in the subsequent events during the online webinars. And thanks to our colleagues from World Health Organization who will be working with us. And also those from the Affiliate for Health.
Innocent, perhaps
you can
switch off your video.
Uganda and all of the
sound is disappearing.
Who have really worked tirelessly amidst the circumstances to make sure that this conference happens. And I am really hopeful that all of us will enjoy this conference. Thank you very much, and all of you are very welcome. Thank you. Allow me at this time, as I said, that we are really building up and borrowing from what our colleagues did in Bangladesh. Allow me to invite Dr. Zakir to really share with us what has transpired since the Bangladesh conference. Thank you very much. Welcome, Dr. Zakir.
Hello, everyone. Good evening from Bangladesh. Wherever you are, all my friends from different regions. So thanks much goes to Innocent and your team, and then Uganda with Wonca, South Asia, WHO, all my friends from rural Wonca. So brilliant job. You know, you are organizing such a thing, and I had experience last year. So it's a tough thing. So you did a great job. And you know, rural health is very important all over the world. We know it before, but in pandemic situation, in COVID, it fingered to us. Primary care physician in rural setting should be as much as possible equipped and evidence-based treatment knowledge and capacity to serve their community. So I hope the conference will give the message to policymakers to collect or recruit health workforce for rural, in those who are in rurally placed and those who chose this career by themselves. So it will more impact on rural health. You know, we have a blueprint last year in our 17th Wonca World Rural Health Conference. You all people contribute there. 6 pages of blueprint, you know, already is on our rural Wonca website and on social media. So things are rolling, you know. in LMIC, most of the things are almost same. In I hope in Bangladesh or Uganda, so many similarities in healthcare delivery system, even in Africa with South Asia. So we have to prepare ourselves. We have to up to date knowledge and capacity building development. Health workforce, healthcare needs, and advocacy and climate change. We put especially COVID-19 on there. So the pandemic maybe will disappear or will be running with. So we hope for the best, but we should equip with our facilities and our service and our commitment. And so many limitation in these sorts of settings. So we have challenge always, because the connectivity, especially I am also suffering the unstable connectivity. Maybe you can't see my voice or my video, because I can see everyone sometimes in innocent time as well. So challenge have, but we have to overcome this. We have to innovate something newer, and we have to motivate our young people. Even we start with our medical student, undergrad student, to what is rural health, what will be the prospect, so what's our commitment in future, how we can ready with this career. So they will be come up with their choice. So this is very important for sustainable rural health service. We can serve so many way, but sustainable things and our own workforce is very important. Rural Lanka have with WHO some 8 elements to how improve with us and career pathway, even in rural pathway pipeline. Thus the rural doctors are not leakage or broken or out of the track. In especially Bangladesh, Bangladesh has tremendous improvement in primary care and rural health. Our infant and maternal mortality is goes down, and our life expectancy is more than before, like around 72 years. So this is the improvement. This health indicator by all the international organization, even in WHO. You can go through WHO website. So you see the improvement, but still we have to go more away to serve most of the people, because most of our people are lived in rural areas, and our doctor and patient ratio is almost 3 to 10,000 population, nurse more than 2 per 10,000. So we have to improve this, and even gap in urban and rural. Almost every region of rural setting is the gap between urban and rural. And specifically after blueprint and my conference, I go through my policymaker in my country. So all people are cordially accepted, and they need some exemplar, they need some evidence, they need some research paper like that. So we have to improve this. And my one urge from all the experiences and conference, those people are working very good in developed countries. Please at least collect people from LMIC, one young researcher or emerging researcher, or even one co-worker from LMIC or developing country for your great work you done. So I see Sabir face, Sabir doing work on primary care like that. Please collect some researcher as well as in Uganda, all the people, and in all LMIC. Even you can ask from other region, even we are interested as well. So we are also working on it with students, with young doctors, and in established physician and other specialties also, to work with us to ensure our rural health and primary care. So all the best wishes for the organizing the 18th World Rural Health Conference from Uganda, and hopefully we will face to face, and we will continue our commitment to Wonca, rural Wonca, and our service, especially in rural population. So thanks, Innocent, again, you and your team, and all the organizers, especially my rural Wonca colleague Bruce, and all my past colleague Jonu Jones is there also, and all my colleagues from rural Wonca Council, all are present here, or audience of your conference. So all the best wishes for you. Thank you very much from Bangladesh. Innocent.
Thank you very much, Dr. Zakil, for the encouraging words. And allow me to invite Dr. Jane Namatovu, who is the president of the Association of the Family Physicians of Uganda, to give her welcome remarks. Thank you, Jane.
A warm welcome to you all. My name is Jane Francis Namatovu, the President, Association of the Family Physicians of Uganda. It is a great pleasure for me to welcome you all to this virtual Wonca World Rural Health Conference. As a group of delegates from all over the world, we represent the primary care providers and trainers in their diversity from each continent that has managed to attend. We are very fortunate as family physicians to meet in this challenging COVID-19 season to continue advocating for quality rural primary care services as well as training. I am positive that what we shall share during this conference over the next few months will impact each one of us in the way we continue to render our primary care services, in the way we continue to train primary care providers, and also I'm positive that it will improve our networks that will ensure that we continue to provide effective primary care services and training. In a special way, I would like to welcome all the speakers from all over the world that are going to share with us their knowledge and experiences in rural health from the different diversities that we are able to host. And I therefore wish and welcome each one of us in their capacities to fruitful deliberations for this meeting, which will continue in the next few months. Thank you very much. On our program, I would like to welcome the President Wonca Africa, Professor Shabir, to give us his welcome remarks. Professor Shabir.
Thank you, Jane, and welcome to all of you. Hopefully you know me as Shabir Musa. I'm a family physician in Johannesburg and also the president of the Wonca Africa region. Together with people on the executive that you might know, like Dan Abubakar, who's the incoming president. There's Joy Mugambi, who's the secretary. Jane is part of it, Elizabeth Reggie, and Kwame Asisi Boateng, and one other person from Nigeria, sorry, Temitope Ilori, and that's the mix, and Innocent often joins us. So I think, just to say, all of you know the predicament that we as Africans are with little resource and many problems, and the difficulty that we have. I think given the sort of African sunny disposition, we tend to see it as opportunity, and all we feel we can offer the world solutions as well, and that our resource challenges are as much an opportunity to show how things can be done better, cheaper, and easier. And we want to be, working respectfully for anyone who sort of sees that as an approach to deal with Africa, and not as us being a basket case for pity. I think Wonca Africa is, an old organization. Actually, it started with, Wonca when it was conceived in 1972, but it still struggles. It has fortunately three new members: Botswana, Association of Family Physicians, the Medcamer from Cameroon, and the Liberian Family Physician Association that brings all members up to 10. We really hope that we can build up more membership across the continent. And it is very clear that that is highly dependent on educational capacity built in country. Of course, the current members are South Africa, Nigeria, Ghana, Kenya, Zimbabwe, Lesotho, and of course, Uganda. The committee, I mean, we try to do things, and I think that we as a committee have been struggling, but online has been quite an achievement. My cat Zura wants to join and see you all as well. The Wonca Women's Party, is very active under Elizabeth Reggie, and I think the Afro one as well under Kwame Asisi Boateng. And there's lots of work in that space being done, which is really gladdening. And I think we have been trying to get other working parties and special interest groups happening in Africa. And one of them is the Rural Working Party. I'm not sure that it is functioning in a coherent fashion as an African entity, but I know that a lot of Africans are involved in the Working Party at a global level, and I think that we all know the importance of it. I think just to mention also the other things that are happening is that Prima Famed is now the official academic organization of Wonca Africa, and the relationship is a strong one where we work closely together. And the African Journal for Primary Health Care and Family Physicians is also, family medicine is also an official journal of the Wonca Africa. And again, they're good, strong relationships, and we hope to support each other going forward. I think, what is very useful for you as members of the global rural family practice community and trying to have this conference in Uganda is to understand what we're trying to do and what has been achieved. And I think there are two important achievements worth noting and worth looking at how to engage with. One is the engagement with the WHO Afro and WHO. So given the agreement by Donald Lee, and I think he'll share that perhaps just now, we have been able to get an agreement between WHO Afro and Wonca Africa to be able to strengthen various elements between us. And I think some of those are just to build a relationship, also to strengthen the district health service through family physicians, noting that the value of family physicians add, and then improving the quality of primary health care in the district health service, and connecting WHO resources with the training of family physicians, and I suppose mutually, and looking at primary care research. So this kind of relationship, and the last thing is support for the development of Afro-PHC, which I'll mention briefly just now. So we've been, having good relationships, having some sort of strengthening of that, and I think that we tried very strongly to get country-level engagements between our member organizations and the WHO country offices, which is an open door, and not too many have taken advantage of that. And I think that is a pity, but that has been an open door. And we, unfortunately, the relationship was built up with Dr. Prosper Tumisime, who retired in November last year. So we're trying to resuscitate it with the new office holders, and that's been somewhat challenging, but nonetheless, much easier than before. I think the other worth mentioning is the African Forum for Primary Health Care, which is really becoming a very powerful space. What happened is at the conference in Uganda 2019, we had a workshop with WHO, and in which we were brainstorming how we might strengthen it. And this came as an idea from the European Forum for Primary Care, as why not set up similarly in Africa. And then we took that forward, and with a number of networking initiatives. And today, as of April of this year, we have a formally constituted board for the African Forum for Primary Health Care, in which your host, Dr. Innocent Besije, is actually the president, and I work as the executive coordinator. And it has a very wide, diverse board and membership. And you can perhaps see that in the editorials that I published in the African Journal, and that will be available on the Wonca World pages. So I think that working relationship that we've developed with both nurses, clinical officers, and in fact community of workers and a range of stakeholders has become enormously valuable. That allows family doctors as part of the team to get their voice through. And I think that what amazes me about that forum is the amount of the sort of the degree of shared values between all these different stakeholders. We're all speaking the same language, and I think that there is in that kind of space an enormous opportunity. So I'm very grateful also to the Wonca Rural Party for agreeing to make one of these webinars, workshops, to be a joint exercise with the Afro-PHC in the next couple of months, in which we can explore together with these kind of stakeholders how we might address rural issues in Africa. And I think we'd hope that you be part of that and support that kind of networking more broadly, especially to address rural issues in the African primary health care team in Africa. So with that, thank you all very much. I wish you well for the rest of the series of webinars. I think that we'll all be here, and we'll try to make sure that everyone interested is aware of it and joins in this, and best for the proceedings. Thank you.
Thank you very much, Shabir. It's lovely to have the cooperation with you in this project, and certainly to be doing that shared webinar with you. I'm just going to now welcome Donald Lee, who's the president of Wonca, and Donald will give us his introduction.
Ladies and gentlemen, let me begin by thanking the Association of Family Physicians of Uganda and Wonca Africa Region for hosting this virtual conference. And thank you to Wonca Working Party on Rural Practice and WHO for working together to arrange the 18th World Rural Health Conference in such difficult and quick-changing times. Hosted in the heart of Africa region, none of you are strangers to the particular challenges of providing comprehensive primary care to rural communities. Working in isolation, often with limited resources and limited recognition, make those challenges even more acute. Our world is a very different place to when we all last met in person. Each of our countries has suffered during this pandemic. Some countries reacted and responded better and quicker than others. Countries which had previous experience of SARS and Ebola were quick to recognize the threat of a virus such as COVID-19, and their results showed that a quick, non-nonsense response paid dividends in terms of reduction of lives lost and reduction of patients requiring intensive care beds. All of us are at different stages of dealing with the pandemic, and we will be for many months to come, as well as dealing with and recovering from the challenges of the pandemic. Many of the key challenges in our health system remain: maternal and child health, access to reproductive services for everyone who wants them, full coverage for immunization and vaccination, treatment of a wide range of chronic illnesses and diseases. These are all still waiting to be dealt with as part of a comprehensive, integrated, person-centered primary care service. Recently called on WHO region and country offices to collaborate with Wonca to support the achievement of universal health coverage. I'm glad that Dr. Moeti, Regional Director of WHO in Africa region, indicated that she is keen to explore what role family doctors can play in developing the various cadre of health professionals, especially in rural areas. There's much to do and much that can be done. As president of Wonca, representing 500,000 family doctors globally, I recognize and argue that effective, timely primary care delivery is not only about doctors, but it is about qualified family doctors being the clinical lead of the professional, competent, multidisciplinary team in order to reach greater numbers and population groups and to deliver more effective care. The need for multi-professional and multidisciplinary teams is true at least as much in rural areas as it is in urban or peri-urban areas. So as we transition from dealing with the most frightening, most challenging aspects of the pandemic, let us renew our goal to expand and develop comprehensive primary care to achieve universal health coverage for everyone, leaving no one behind. Have a good conference. Learn from each other. Talk to each other about your experiences, both good and difficult. Above all, be proud of what you have achieved over the last year, and let's renew our efforts to get everyone vaccinated against COVID and recommit to developing comprehensive primary care around the world.
Thank you very much, Donald. And it's, I think, a pleasure having our president to talk to us at such a forum. I'd like to just welcome you to the forum more generally from rural Wonca, and I'll just first of all like to thank the organisers in particular. Particularly like to thank Jane as president of the Ugandan College of Family Physicians. These are difficult times, and I think you've done a marvelous job in getting this together in a period of lockdown. Innocent, you've been working on this for some years, and it's been a real labour of love for you, and we thank you also for your efforts. And Shabir, thank you as the president of Wonca Africa, in particular, for your marvelous efforts, particularly with Afro-PHC over recent times. And we are very much with you about the need for this to be about primary care more generally, not just about family physicians, but about the team, about making sure our nurses, community health workers and others are carried along with us, and that we provide appropriate support for them as part of a primary healthcare team of rural generalists. We're also very proud in this conference to be working with WHO, as I said, with Afro-PHC as well, and also thanking very much Network Towards Unity for Health for their partnership that they've had with us. They partnered with us in the 17th World Rural Health Conference, and it was quite a struggle to get that up and running, and you can see some of the wonderful times we had at that. And we got some wonderful virtual tours of Bangladesh. The virus has not been pretty. It's certainly not something that we would have wished on ourselves, and the loss of life and the dislocation that's caused has been quite terrible. But it has had a silver lining in a way that it's allowed us to democratize the participation of doctors from all around the world. We found it really must have take control of the agenda in lower and middle income countries. We needed to make sure that we embraced that agenda. And Bangladesh and Uganda have been our opportunity to do that. We were hoping to visit Zakur in Bangladesh. We were hoping to visit Innocent and Jane in Uganda, but as we said, the virus has stopped that. But it has allowed participation from all around the world, and we decided that we would go online with this conference, as Innocent said, in a way that allowed everyone access. Rural Wonca's got a proud history right from some of the first discussions way back in the 1980s about rural healthcare. You can see some of the principles back there through training for rural general practice, rural health, and our cooperation with WHO in the guideline on health workforce development, attraction, recruitment, retention in rural remote areas. It's just recently been published. One of the things that came from the conference in Bangladesh was the Wonca blueprint for rural health. And I encourage you all to have a look at that. It's on the Rural Wonca website. It's got a few key principles which are not unexpected. The importance of advocacy, primary healthcare, and that's comprehensive primary healthcare, such that it includes emergency care where it's needed, hospital care, and even advanced skills such as obstetrics and surgery, particularly in areas of need. There's a need for universal healthcare as well, and that's one of the key topics of this conference. The need for public health and community infrastructure. The need for access, as Roger Strasser says, there's three problems for rural access, and access. And part of that is access to workforce. But not only are those the principles that have been advocated in the blueprint, but there's also a number of important concepts that are in there. The need for end-to-end planning and the integrity of that plan, need for clinical courage, and I'd encourage you to have a look at the paper in the BMJ about clinical courage, the need for rural doctors, rural family physicians to step up and advocate for their communities and have the courage to do that, about having rural health education in rural for rural, that it's about the teachers being in rural and not elsewhere, the need for immersive community engaged education that allows us to have students as part of the healthcare team, about rural exposure, making sure that a little bit of exposure is good, but certainly the more is better, allowing communities to grow their own workforce. A number of other principles around redundancy, making sure that there's backup in rural areas. We're right at the end sometimes of the production line, and be able to make sure that we've got those redundancies. In the Philippines, step-ladder education has been shown to be excellent, where people can go through various parts of their career. We've needed and have engaged young doctors. Our rural seeds are an exemplar of that. There's a need for the right health worker in the right site. As family physicians, we recognise that in smaller communities, there's a need for nurses, community health workers to be supported by rural doctors, and that all of us need to be rural generalists. We all need to have a broad range of skills. We see the importance of rural origin, and that's important, but that burden can't fall on people who come only from rural areas. We must also be able to ruralise and inspire city medical students to become rural doctors. We see the importance of rural policy and we see the localizing of economic benefit in rural areas as being terribly important. So there's some of the concepts that came out of the Bangladesh conference. But now what we're doing with this conference is moving towards the African focus. And I think that's the real benefit of this conference, that we can get that input from Africa. There is terribly large need in Africa for rural doctors. Some areas have very small rural doctor numbers, or even health work numbers of anything of any type. So we want to support that, and the idea of having this conference in Africa is to do that. I really liked the other day that the Journal of Rural Remote Health decided that they won't publish anything about a country unless there's an author from that country. And there's a saying we have in our Indigenous populations in Australia about nothing about us without us. So we're really looking forward to hearing the African view on rural health during this conference. So thank you very much, Innocent, for arranging this conference. And I'll hand back to you to introduce our keynote speech. Thank you. Go ahead, Innocent.
Yes, thank you very much, Bruce. I'm sorry, I just got a brief interruption with the network. We are sorry. The next on the agenda would have been the WHO representative for Uganda, but as you have heard that we are in turbulent times, I think we are not really able to have him with us, and he was also not able to record any message. But hopefully we shall have him in our subsequent events. But at this time, you allow me to invite our keynote speaker for this event, Father Dr. Okoli, who is a family physician and a Catholic priest who's serving in the northern part of Uganda. He is a director of one of the general hospitals in the post-conflict northern Uganda, and he has really done tremendous work over there. He has improved both clinical and laboratory services, but as well as the outreach activities of the hospital. So this afternoon here, where we are, and the morning and the evening for the other colleagues, we are privileged to have him to share what he has done and how he has done it, and hopefully what we can learn from him as family doctors serving in the rural areas or in the different parts of the world. Dr. Samuel, you are welcome. Dr. Kora, are you with us?
Can you hear me?
Yes, we can hear you now. I see you were having difficulty getting the connection, but we can hear you. Yeah.
Yes, I got a problem. I don't know what happened. Yeah, but I can hear you now.
Good. So you can share your presentation and then we start to move forward.
I'm not sure whether I can share because I'm using my phone right now. So can Professor Bruce share what I gave him or you?
Yes, I will do that, Samuel. I'll bring that up now.
Thank you so much. Thank you. Okay, so can everyone hear me?
Yes, we can hear you. Please go on.
Okay, thank you so much. I'm Dr. Samuel Okori, the medical director of Aber Hospital. I'm very privileged this evening or this morning to share with you the vital role of family physicians to improving rural health. And this is a case of Aber Hospital in northern Uganda. I will share with you mainly the first thing is the clinical practice in the hospital. And I'll share with you the role of family physician and the barriers to improving rural health and strategies to improve rural health and some few take-home messages. That is the outline. So St. John the 23rd Hospital, Aber, this is a Catholic founded hospital since 1953, became a hospital in 1969, and it's mainly to care for the community. The beneficiaries are the people in the rural areas, a bed capacity of 220, and with a population of 50,490. These are the people that we are responsible for. But we get so many other referrals from other health facilities and from other regions and from other districts. This hospital is a general rural hospital, and it's also a health sub-district, and with 24 lower level facilities. So I am the head of the health sub-district. So there are 2 health sub-districts in the district of Oyam, and this is very important because it helps to bring down the services and promote the equity and accessibility of the medical care. The hospital is as almost all major medical disciplines. We have surgery, medicine, all that you would expect for a hospital or a rural hospital, general hospital, or a district hospital. And this year we received the first cohort of medical intern doctors, 8 medical intern doctors. So we have become a training center for the doctors in Uganda. So we are very happy to do that. You may not see the map very clearly over there, but where the H with green, that is where the hospital is located. It's in the mid-north of Uganda. So the H is where we are located. The next slide is the aerial view of the hospital where we work, where we live. It's really a rural place, you can see, but it has the major infrastructure to take care of patients in this rural location. You can see the nature over there, very beautiful place, fresh air, and so that is very important. Then the next slide. This is just a part of the hospital where we work. The guy in the picture, in orange, that is the laboratory. The laboratory that was accredited this year. I'll show you in the coming slide. So I would like to talk about the clinical practice in the hospital. The clinical practice in the hospital comprises from emergency care services. We have a 24/7 emergency ambulance that takes care of emergencies from the lower health facilities, the lower level units, going up to almost 60 kilometers away from the hospital. And we have emergency unit, which is well prepared to receive these emergencies, be it a road traffic accident, be it diabetic ketoacidosis or hypertensive emergencies, ready. And then also the maternal child health. We have a 24-hour maternity ward that receive mothers who need operation, those with obstructed labor. So this is very important in a rural setting. This saves lives, the emergency care services. We also have the in and outpatient and outreach activities. So the outpatient, the inpatient. We also have supporting facilities. We have a newly accredited laboratory, the first accredited laboratory in the region. We also have a newly installed CT scanner. Instead of going to Kampala, going to Mbale, going to very far away, we can do these services for our people locally in the rural area. And then we also have a fully stocked pharmacy for in and out patients. I think the next slide is just about the lab technicians working in the lab. You can see there, yes. This is our newly accredited lab, and it's the only laboratory accredited, so that when you do a test here, you don't have to repeat it. So this saves money. This saves our rural people from going far away, going to India, going to Kampala. So this is the way we are contributing to the rural health. The next slide. This was just this year, May 29th, when we had the commissioning ceremony of the first CT scanner in northern Uganda. This was a very big achievement for us. This was with the help of our friends from the United States, who have been raising money for this community for the last 4 years, and we are able to have this equipment to serve our people. The next slide is about what takes place in the hospital almost on a daily basis. Every Monday from 8:30 we have a clinical review. We review the cases 1 hour. We have grand round, and we have the doctors who participate, the nurses, even the clinical review. We have the specialists, the in-charges, the medical officers, to review what is going on in the hospital in terms of clinical care. Every Wednesdays, we have the CPD. We already have the program for the whole year that helps each department with other important topics to be discussed. And this is for the whole staff in the hospital. Every Tuesday, the third week of every month, we have the MPDRS, the maternal perinatal death reviews and surveillance. This helps us to improve our care of our patients. We also have special clinics, the diabetes clinics, and all these are their specific days where we see clients who need that. But above all, without the material resources and finances, we cannot do anything. So administration, the way we run the resources is very important. So the finances is important in this. Next slide. I'm going to talk about the role of the family physician. In the first place, the family physician should be ready, or I am ready to provide all-round care at any level. To care, to show the humanity of care, should be skillful in communication. Listen to them, listen to the clients when they come. Whoever comes to me, I have to listen, I have to give time to listen. I have to provide leadership. I am the medical director of the hospital, and a lot goes on to make things move together with the team. I have to promote good governance, not only in the hospital, but in the district and also in the health sub-district. I have to promote actually the quality health care. This is very important because I have to make sure that the one who comes to the hospital is safe, it is centered on the patient. We respect the values and the beliefs of the patient. We have to make sure, I keep saying we have to make a correct diagnosis to treat correctly, and should be evidence-based. That is what I do as a family physician, to make sure the patient, even patient's rights are respected and values. Next slide. My role is to practice and promote family and community-oriented primary care. What do I mean? Every time I see a patient or a client, I have to ask about the family. How is the family? There was a day I asked someone, he said, oh yeah, it is good you ask. I just lost my wife. You see that? So, and then also the community. I have to connect this family with what is happening in the community. I am the link between the health facility and the community. Every time I see a client, this is what I look into, the family and the community. I have to make sure the community is involved. Every year we organize what is called the annual health assembly, the key stakeholders, to listen to them, to get a feedback from them. And this is done yearly, and has been very important for us to listen to the community. Next slide. Every day, Monday, Tuesday, Wednesday, Thursday, except Friday, I see patients, the clinical care of patients. I make sure I listen to them, I find out what is wrong, I make a diagnosis and treat, and also do the ward round. And I have to make sure that I listen to them, to the patient, ask about the family, the community, and I have to continue with care of these patients. I have to make an appointment, come back at this time, and this is supposed to be holistic care for our patient. Every time I meet a patient or a client, I take it as a moment of health education, how to prevent diseases, hand washing, sanitation and hygiene with the person and also at home. Next slide. We have students. We have nurses, we have medical interns. We have to continue teaching them, to mentor them, so that they get to do the right thing and improve on their skills. Not only that, I have to mobilize resources for the hospital and health supplies for the community, as we will see in the subsequent slides. I have to coordinate the community services, as we will see in the subsequent slides. We have radio programs. Once a month, we conduct radio programs on different topics. Some of them can be road accidents. We engage the community, they call back when we identify a radio station to talk about the health issues of the community. Next slide. So those were the role of a family physician. Now I talk about some obstacles to achieving rural health, barriers. The health facility should have the software and also the hardware. Not only the infrastructure, but also medicine. Medicine must have equipment, should be able. Can you hear me? Are you able to hear me?
Yes, go on. I think somebody needs to mute, but we are hearing you.
Okay, thank you. Yes, I was talking about the barriers to rural health. It is not only about the infrastructure, but in this building, are there lab equipments? Are there medicine? So both the software and the hardware are important, but these are lacking. And then also limited access, not only to health, but mental health, psychiatric problem. I see many people moving on the street with psychiatric problem. This is because the rural areas do not have these facilities. Even the oral care, the oral hygiene have a very huge impact on the health of a human being. In these areas, there are few skillful human resources. They may be few, but if they are skillful, it's okay, but they are few and not skillful, I mean. In this, some of the barriers actually are long waiting times. This is not for the hospital where I work, but in the surrounding lower facilities where I supervise. This is a very big problem. Another barrier is the cultural beliefs. A client may say, my problem is does not need a hospital. It needs a witch doctor. My problem is my neighbor. It's not a medical problem. These are barriers to rural health. So it may not make them sick to all go to the hospital. Next slide, the geographical isolation. Very poor road transport system in this place. Very, very poor. And this is a big barrier too. The next one is the health illiteracy. The inability to comprehend basic information on health, even inability to maybe read information, inability to even take the health information seriously if they ever hear it. This is actually a silent epidemic, very big problem. It has a huge impact on health. Low socioeconomic status. Yeah, the rural people where I work, yes, they may not have even money, even the way of life, low level way of life, limited job opportunities. The Ugandan system of referral is excellent, but because the rural facilities are not well equipped, patients pass the thesis that I wrote for to be published. So that is one of the biggest challenges also, bypass phenomenon. Next slide. Yes, I have to look at the strategies to improve rural health. It must be family and community oriented. And what do I mean? We have to involve the family. We have to, any intervention should be based on the need of the community. We may think it is the medicine. No, it may be food. clients or the rural people have to participate in their health. We have to continue with health education, integrated support supervision that we do quarterly. Those lower facilities, we visit them every quarterly to continue with sensitization. And then also integrated immunization. We do the deworming. We go to the lower facilities. We go to the communities to carry out these immunization drives. Next slide. This is just a picture of one of the villages that we were doing immunization. We have a team from the PHC in the outpatient department that go on a scheduled days to go and do immunization. Next slide. Next slide, please. Yeah, thank you. Among the other strategies to improve rural health, we have endeavored to encourage our people to save for health saving schemes. Yes, we have about 10 groups that are saving for their health. In the past, they used to save for death. There's a big difference. We had to intervene. They were saving for death at the time of their death. We had to intervene and say, no, you have to save for your health, not for your death. So this is a very big achievement that we have done for the poor. We also have annual medical camps, and where we have surgeons and eye specialists from Uganda and from other countries that come to go to the rural areas to carry out some of the operations that our people cannot afford. I have already talked about the ambulance services for mothers and child. So next slide. This was January 2020 when we had a team from Belgium. They had come for the eye operation to provide glasses. So this was in the hospital, and a group of that team had gone to the villages. So they would send in those who would need eye operation, cataracts operation. So this was actually in the hospital. This was last year. And this is free. We carry this free so that our people can gain their sight. This was just one of them. Next slide, please. We carry out telehealth or telemedicine for antiretroviral drugs for the different communities in the villages. We have what is called community drug distribution points, and there are 33 in a catchment area. Each distribution point has about 70 clients, where we take ARVs to them. We take to them, but they must have their viral load suppressed to qualify. We have about 5,000 clients on ARVs. And the good thing is that 96% of our clients have suppressed viral load. This is the beauty of this. Next slide, please. Yes, this is one of the distribution points where we take the medicine for them. Next slide. Yes, we also carry out the HIV testing services to the communities, but more importantly is the assisted partner notification. This is very key because we identify those who are HIV positive after testing them, and we ask them to consent to notify their sexual partner who might be exposed to HIV. This has a yield of about 30%. So this helps to identify, to find out those who are HIV positive so that this problem is resolved or reduced. So this is a very big achievement also in terms of the community outreaches. We also carry out the quarterly, the community TB tuberculosis sample collection. We go to the communities or quarterly, but because of COVID, we can't do now. We go and we take the sample, sputum sample, we bring them to our laboratory and we give back the results. And we find that so many people were having tuberculosis and we have to begin treating them with anti-TBs. Next slide. Yes, it was a rainy day, and this was one of the villages where we did the tuberculosis sample collection in one of the villages. Next. Among the strategies that can be done is to retain the qualified medical personnel and to provide financial incentives to those working in the rural areas. It's a very big challenge because not many people would like to work in the rural areas, and then also to improve the working conditions. This actually goes to the government, the stakeholders, to take rural health, the role of family physician, to improve rural health very seriously. And then there are also needs for close cooperation between the clinical care, the hospital, and the family physician to support the role of the family physician, the duties of the family physician. Next slide. Yes, other ways to improve rural health, equitable access. Equity here, I think the next presentation is about equity. Equity here is important because there are people who are short, others are tall. So for them to watch football, you can give a stool for the short one to stand to be at the same level with the tall guy. So that is equity. We try to support. That's why we charge our fee at a flat rate. A cesarean section in this hospital is actually $10 because some can't afford. But for those who can afford, it can be $100. That is the maximum, so that you can balance those who can afford and those who cannot afford. Efficiency, we are a limited resource setting. We have to do things right with the limited resources. Yes, another important point that I mentioned earlier on is to provide quality healthcare services, which should be evidence-based. I mentioned this already. Next slide, please. The health resources should be adequate, available, and utilized. Be it in public facilities, be in private facilities, these resources should be provided to rural areas if we are to improve the rural health of our people. The next bullet is very important because we have to improve the patient-centered involvement, patient-centered health system. What we do should look at the human person who is in front of me. What are the beliefs? What are the values? Then any reform should focus on strengthening primary health care. Lastly, I have the key messages, few messages. The improvement of healthcare in rural settings is a collective responsibility of the patient, of the family physician, of the hospital, and the government and the stakeholders. The family physician should endeavor at all times to promote health education, prevent disease, promote health, and connect the family and the community. Improvement of medical supplies, diagnostic equipment, and human resource for health are key if we are to improve the rural health. Communication is very key with and support from rural hospital to the family physician, and the family physician to communicate with and to the families, the patient, and the community. Trust is very key to establish trust between the family physician, the healthcare providers, by the communities, like we do for the annual health assemblies. Lastly, but not least, I'm just wondering whether it is even possible to have, for us, family physicians, to have a position paper on this very important topic, the vital role of family physicians to improving healthcare, and even Wonca. I think I have to stop here. I thank you so very much. If you have any comments, please, you're free to come in. Thank you so much. Bye.
Thank you very much, Sam. And I think we've got a few questions here. I'll just get those underway. There's I've just lost them for a moment. There was some a question about your experience in COVID with your health system and trying to get out into rural areas during times of COVID. Would you like to make any comments on that?
Oh yes, right. At this point, we are not, because of the lockdown, we are not able to do as we used to do. But we had supplied most of our clients with the medicine that they need, especially ARVs. But the government has allowed those clients with serious conditions to come to the hospital, or we can go to them. But because of the COVID situation, we are not able to conduct community activities at this point.
Got a bit of noise in the background. I'll try and isolate that out in a moment. But the other thing is about task shifting to provide primary care at a community level, and just the relative cost effectiveness of those sort of strategies. I think we all recognise that a layered sort of strategy with families, physicians being able to assist other providers to reach a high level of care, and for us all to work at maximum capacity is important. Would you like to comment on that?
Yes, if I get you right, yes. The idea of the family physician cannot do this alone. There is need for collaboration with other medical practitioners, with other health workers to achieve this. I don't know whether I got you right, but the point I'm making is there is need for collaboration with the family physician, so that he doesn't do all these things alone. That is the challenge. I don't know whether I got you.
Yes, I think you did. From what I heard with that, it's about making sure we all work as a team to the maximum effort. There's also a question about some discussion around, and I noticed you had it in your talk about primary or private services and hospital services or public services working together. What's your experience been of that?
Yes, the public facilities, the government facilities, the private facilities with good eye because of the user fee, the small contribution that the community has to give, especially for the private not-for-profit hospitals or facilities. But in Uganda, actually, the private facilities or the private providers provide almost 70% of the healthcare in Uganda, almost 70%. And the private not-for-profit like we are, we provide more than 40%. But you still find that at times we are not given enough support. Yes, the government supports in terms of PHC, to help with immunization, to help with running with medicine. Now we have the credit line from the government, but at times the working relationship is not so good. Above all, during this time of COVID treatment in Kampala, there's been a very big problem that the private facilities are overcharging patients with COVID. And this has brought a lot of discussion. But all in all, the public facilities should actually work hand in hand with the private facilities. There is a partnership, private-public partnership for health. But this is very good in the paper, but at times in practice, not so good.
Yeah, it's a struggle, I think, to get that cooperation between those services, but so vital if it's going to be an effective use of the community and government resources. I've got a question here also from Roger Strasser about, you mentioned you've got, you're a training institution for interns. Do you have medical students and family medicine trainees in your hospital there?
Unfortunately, we don't have anyone yet. We don't have any. Yeah, we don't have. I would love to have. I would really love to have. We have those in the major disciplines, in medicine, in surgery, in pediatrics and OB/GYN. I wish we had. That would be very good. We don't have yet.
Yeah, I think Roger himself has actually done a wonderful paper I'd recommend to you for the World Bank about immersing all students, medical students and family physicians in this these sort of environments. There's a question too about the community health workers' involvement. They're obviously fairly vital to do some of the care that you're wanting to happen in the more far-flung communities where that road transport is difficult. Would you like to comment on that?
Yes, in those far places, we have the vehicles. We have the land cruisers that can actually travel in bad roads, and we have community health workers, but these are the staff of the hospital. We have to arrange with them because we cannot get other people from somewhere else. So we arrange with the hospital staff and we go to those areas, to those communities every Friday, twice in a month. Every Friday, we go to those communities for support supervision. The roads are bad, but we have to try to maneuver to reach the lower facilities and those communities. We use the community health workers that we have, but also we have the village health teams in those villages who can direct us where there are challenges. We have a client here, so they can call us and we can call them and we connect with them and go to visit, or we take the necessary help that they need.
Yeah, so notice Roger's just putting up the reference that I mentioned about the World Bank document. I think everyone might find that quite useful. Do you ever take medical students out with you when you're going on these trips to community? And if so, do they get to stay in community at all?
No, they don't stay in the communities yet. They just go for a day and they come back. because here they cannot stay, but we have accommodation for them in the hospital, and they live here and they work here. They don't go. We take them to have experience of the community, but they don't stay there because there is no accommodation, actually. Yeah. Yep.
A problem all around the world. So I think we probably need to move on. Thank you very much for a very inspiring lecture. And we might give a few claps on the, if everyone looks at the reactions there, we might see if we can do a few little claps there along the way. So thank you very much. And we will take you up on that offer to work with you during this series to try and make sure that the African and particularly the Ugandan voice is heard in these discussions that we're having at the conference and with WHO. So thank you very much, Father Dr. Samuel Okori.
Thank you very much, Professor.
I'll now like to just introduce Theodore Swift-Kohler, who's a Senior Technical Advisor Equity at the World Health Organization in Geneva. Theodore actually grew up in a disadvantaged area in the United States, in a indigenous with an indigenous community as a young child. I've talked to her about that, and that I think has shaped her view of the world about equity for rural areas. She leads the production of guidance and supports member states in assessing barriers to health services and reorientating health planning and programming to be more equity orientated in the context of reforms towards universal health coverage, which we're all trying to achieve. She's also active in inequalities work at cross-UN levels, represents the WHO at the United Nations Inequities Task Team, the ITT, and co-leads a subgroup of the ITT on tackling rural poverty. And in fact, I was quite stunned to hear that 4 out of 5 of the world's extreme poor live in rural areas. Many of those are indigenous people. Before a time at WHO headquarters, Theodora worked on health system strengthening at WHO India country office and the WHO European Office for Investment for Health and Development, coordinating work on social exclusion, poverty and health, during which she also worked on rural health issues. So it's a great pleasure to introduce Theodora and to ask her to address us about the WHO aspects of this partnership that we have on this conference between rural Wonca and the rural equity area in WHO. Over to you, Theodora.
Thank you so much. I am just going to now connect my presentation so you all can see it, and please let me know if it comes through. Can you all see my screen?
Yes, we can. Okay,
brilliant. All right, well, it's really an honor to be here. I've enjoyed the interventions and the presentations and really been learning a lot, and I feel honored to be able to exchange with you all on these issues and be part of this opening session. So today I'm going to talk briefly about rural health equity and also outline some of the webinars that we will be convening linked to this conference over the next months. And I want to start out touching on the issues related to extreme poverty that Bruce mentioned in the introduction. So first, indeed, there's 4 in 5 people living in extreme poverty who actually live in rural areas. Also, the multidimensionally poor people globally, 85% of them live in rural areas. From a global equity perspective, focusing on the rural population is particularly important, given that we have 67% of the rural population in terms of the total population in income countries living in rural areas, and 60%, almost 60% in lower middle income countries. The UN is committed across UN levels to focusing more on the needs of people experiencing extreme poverty, including in rural areas. We have a UN framework for action. WHO within that is committed to serving populations experiencing vulnerability, including extreme poverty, and reducing health inequities given the intrinsic links between poverty and health equity. Also, from a human rights perspective, it's critical that we tackle health inequities in rural areas. And I want to say not only from the deficit perspective here, but also if we consider the importance of fulfilling human rights as critical contributing to social and economic multiplier effects, i.e. contributing to economic growth, social cohesion. I believe that there's somebody on mute. I'm wondering, somebody who maybe could be muted. Is that possible, Bruce? I'm hearing a lot of conversations. Okay, great. All right, I'll go on then. So what do we mean when we talk about health inequities? We're talking about differences in health that are unfair and they're remediable. So I want to say that health inequities exist in all countries. So low income, high income, anything in between. And also they can manifest across all types of ill health. And so I'm just sharing two examples here. In 1/3 of 47 low and middle income countries studied, the under 5 mortality rate was 20 deaths per 1,000 live births, higher in rural areas than in urban areas. And evidence from multiple countries show that people with NCDs can face greater challenges in accessing timely and appropriate services in rural areas. So with regards to approaches for tackling rural health inequities, and I think that the presenter, Samuel Okori, before me actually very eloquently described from a frontline perspective many of these entry points. We see that there's really a two-tiered approach that needs to happen, strengthening rural health systems, as well as cross-sectoral work on the determinants of health. Because the health inequities that we see in rural areas and also more globally, they're really driven by factors in these two domains. As was mentioned by Bruce, I come from a background of doing assessments of barriers to health services, and we really see these two aspects as critical. So with regards to strengthening rural health systems, key entry points are indeed health financing, ensuring that there's adequate funds available and that the funding flows through decentralization are proper to ensure resources needed to provide the health services. Then there's information systems that enable us to have the information required for policy and programming decisions that can tackle inequities, health governance that includes looking again at decentralization issues, but also intersectoral action and social participation, indeed the health assembly issues that were mentioned before. Human resources, as you all know and has been mentioned by various speakers, WHO has recently come out with updated guidance on human resources for health in rural areas. Then the service delivery platforms, whether it's challenging current divides presented, for example, with regard to specialized services and how we can challenge those divides by expanding telemedicine, and then also looking at the platforms such as rural mobile health units in disadvantaged, very remote areas, and also health products, and these can be related to the availability and accessibility of medicines, but also assistive devices, other products that are needed just for the proper functioning of health services. So there can be inequities across all of these, and bottlenecks and barriers, and that can drive health inequities experienced by the population. And then when it comes from to the side here and working at cross-sectoral levels to address determinants, as was mentioned by the previous presenter, we see employment issues, either on farm or off farm, key challenges with unemployment, underemployment, employment in the informal sector, lower education levels in rural areas, lack of adequate social protection, land ownership issues that further drive lack of proper civil registration. Without civil registration, then it's challenging to be able to access the range of social services, including health. Issues with infrastructure that cause barriers to health services, whether it's road or it's linked to Watson. Also challenges with electricity and how electricity is actually a key input for quality health services. Issues with ICT connectivity that can limit the potential to make use of platforms such as telemedicine. Then there's issues related to natural capital, and natural capital, it's really important for us to look at this from the environmental health perspective, ensuring that environments don't create the circumstances for increased exposure to risk factors through contamination or through, for example, in the case of NTDs, facilitating that disease vectors can perpetuate. Then also from the determinant side, we have to look at things like gender equality. And here, when we analyze data from DHS, we can see that many women still face challenges in actually having power to make decisions regarding their own health and care seeking. And so challenging these adverse gender norms is critical to overcome health inequities experienced by these women. Then there's discrimination that can be based on ethnicity or migrant status, and these are also factors that drive health inequities. And so a way to really overcome some of these inequities that we see on the determinant side is through very strong multi-sectoral rural development planning and backed by strong information systems across sectoral domains. And that is an area that globally is rather, let's say, it needs a lot of work. It needs a lot of work for all the SDG targets that are lagging behind in rural areas. This is a key focus. And so across UN levels, we are committed to doing more. And then also with regards to rural proofing sectoral policies, by seeing if, for example, a national health policy strategy plan, an education plan, infrastructure plan, Watson plans, if they're all rural proof, this will help both strengthen rural health systems, but also strengthen action on determinants of health. So just to quickly fly through some examples more in depth. Here, I just wanted to say an estimated 2 billion people living in rural and remote areas across the world do not have adequate access to essential health services they need within their communities. And as mentioned before, improving the attraction, recruitment, and retention of health workers in remote and rural areas is really part of addressing this. We know that rural populations tend to experience higher incidence of impoverishing health spending when compared to urban areas. So not only when we think of health financing is it important to think of do health services and providers in rural remote areas and district governments have the monies that they need, but also what are the financial barriers that the population can experience when trying to access those services. Do they face impoverishment because of the fees that they have to pay? Or do they go without getting the services, i.e. do they have unmet need? And so having this affordability of services in our minds is really critical moving forward. Also, with regards to information systems, WHO did some review for our recent 2021 World Health Statistics report. We did reviews of household surveys in 133 countries, and only 70% of those surveys collected data disaggregated by urban, rural, and only 58% by wealth. So, we really need the evidence, we need the information on these inequities to be able to champion the cause with national and subnational policymakers and planners. With regards to social and environmental determinants of rural health, just giving some data here, nutritional status and dietary habits are often worse in rural areas. The prevalence of stunting is higher in rural areas and in poorest households. Climate change will impact the health of the rural poor. And one way that this will happen is through, in particular in tropical countries with limited access to safe water and adequate sanitation, increasing average temperatures and precipitation variability will likely increase the burden of diarrheal diseases. In almost a quarter of countries with data, agriculture appears among the top 3 sectors in terms of the share of fatal occupational injuries. 70% of the rural poor depend on livestock, and they are more disproportionately exposed to zoonoses as a risk factor for human disease. And then when it comes to Watsan, 8 out of 10 people still lacking even basic drinking water services lived in rural areas, and 7 out of 10 who lacked access to basic sanitation services lived in rural areas. So really, it's a critical moment in time now to focus more on rural health. And we've seen through the COVID-19 crisis that really there's an underinvestment, a chronic underinvestment in rural health systems and in determinants of health in rural areas, both in LMIC and HIC. And this has been exacerbated, and really we've shined the light on it in the COVID-19 context. We've seen that in rural areas, based on the data that is emerging from different researchers, and I have to say there's not enough data on this, but what is emerging, we see that there's inadequate numbers of appropriate trained health professionals to response in rural areas, poor facilities and infrastructure, including limited capacity in rural clinics to treat severe disease manifestation, shortages of key health products such as testing kits, PPE, vaccines, weak referral systems and inadequate safe medical transportation, weak information systems and civil registration in the case of deaths, and financial, geographical, and organizational accessibility of public goods and services is challenged. We also see that there's reverse migration from urban areas to rural areas, further straining fragile rural health systems. Also, some pockets in rural areas, in particular, pockets of the population with high community connectivity, high levels of crowding in households, inadequate water and sanitation services, they're particularly vulnerable. And this is also linked to the fact that they have lesser access to quality health services. This can result then in higher mortality. WHO has a survey called Pulse, and it aims to track continuity of essential health services during the COVID-19 pandemic. The data isn't disaggregated by rural urban, but it does show that for some diseases that are disproportionately impacting the rural poor, such as neglected tropical diseases and malaria, that they are considerably disrupted in the current context. So really at cross UN levels, we're highlighting not only the situation that rural health systems are under, but also of all public services in rural areas, and saying that in the context of building forward better, we need to invest in these areas. And here on the right side of the slide, you're seeing a forthcoming report on this area, on this issue. So in this context, and also linked to the fact that World Health Day 2021 is focusing on health equity, we have joined forces for this Rural Health Equity webinar series. It will span from July all the way through February. It'll cover a range of topics, including those featured here. I'll just quickly go through them. So the first is on rural proofing of health policies, strategies, and plans and programs. The next is on the occasion of the World Indigenous Peoples Day, the 9th of August, and it'll look at social participation, inclusion, and community engagement approaches for the health of Indigenous people in rural and remote areas. On the 15th of October, we'll look at policies to develop, attract, recruit, and retrain health workers in rural and remote areas, with a particular focus on gender equality for rural women through health workforce policies. On the 4th of November, we'll look at innovations in equity-oriented health service delivery in rural and remote areas in LMIC. On the 25th of November, we'll look at intersectoral action with the agricultural sector, a major employer in rural areas, for strengthening primary health care. On the 16th of December, we'll look at improving rural health information systems for health equity. And the 17th of February, rural women and addressing inequities in health service coverage. The partners, as you all know, are Wonca Rural Working Party, the Rural Poverty Subgroup of the, it's the ITT, the UN HLCP Inequalities Task Team. OECD is also joined as a partner, and then various academic institutes, and then of course, for country-specific case studies, we have government representatives, as well as civil society organizations and other partners. So just on an upcoming webinar, the first in the series, it'll be convened on the 15th of July, and it will focus on lessons in rural proofing of health policies, strategies, plans, and programs. I hope you all can come. We'll have country experiences from South Africa, United Kingdom, and Chile, as well as OECD presenting some cross-country analysis. We'll also have the new WHO Universal Health Coverage Social Participation Toolkit be profiled in terms of how it can be used in rural settings. And then of course, we'll have Bruce come from the Working Party on Rural Practice to also share insights from Wonca in this area. Then on the 9th of August, as I mentioned, we'll be looking at social participation, inclusion, and community engagement approaches for the health of Indigenous populations. We'll have UNDESA, an Indigenous woman there who works in their Indigenous persons unit. She'll co-chair with me, and we'll be covering country experiences from India, Brazil, United States, Canada, Mali, Chile, and Australia. And we'll be forthcoming soon with the connection details for that. So I just want to end by saying thank you so much for this opportunity to share with you all and to partner on this very important area. We hope this is the initiation of stronger partnership also in the years to come. And it's really an honor to be connected with you all. Thank you so much.
Thanks so much, Theodora. It's lovely that you share our passion for equity and particularly rural health equity, and we're really looking forward to the upcoming series. We've just had a couple of questions about sharing your slides, and I will just check with you on email, but providing you're comfortable with that, we'll put them up on our ruralwonca.org website under the 18th World Rural Health Conference, so that others can see them and reflect on those. So thank you very much. I'll hand back over to Jane, who's going to introduce our final speaker.
Thank you very much, Bruce. As we come to the end of our session, I would like to introduce Dr. Upentho George, who is a family physician working with the Ministry of Health, and he's going to talk about what the ministry is doing to improve health of rural populations in Uganda, the efforts that they are trying to ensure that that happens. Dr. George Upentho, you're welcome.
Yeah, thank you very much, and good morning, good evening, good night, and I don't know to whoever is there. Thank you for giving me this opportunity. Can you allow me also share my screen briefly?
Please do.
Okay. Let me start with that. And I hope you can all see that screen.
Yes, we can.
Are you able to see that slide?
Yes, we can see the slide.
Okay, okay. Yeah, thank you very much. Okay, when I was asked to come to this meeting and talk about what mental health is doing to improve the health of the rural population of Uganda, I thought of putting a few things on the slide so that it remains on record. But foremost, I want to say thank you to the Wonca fraternity and particularly the family physicians of the Family Physician Association of Uganda for making it possible that this conference takes place. I bring you greetings from Uganda and greetings from myself. Those are my names. I call myself Dugum George Upento, like has been said, and the Commissioner of Health Services for Community Minister of Health of the Republic of Uganda. I'm a family physician, and I also have a public health background. And my submission will basically do my discussion. I want to start by giving you a small brief about what Uganda is going through. Uganda is going through a second wave of COVID. It's has we anticipated it, and so we also try to prepare for it. The bad side is what you all know. But the good side of COVID decrease. This is the first time town has made huge estimates in make the rural population, the urban population, and even the refugee population very comfortable, even when they go through these very terrible and big moments in their lives. And with these investments in the country and new reforms and health, and so we You lost me because of some network problem, but I think I'm back. I hope you can hear me.
Yeah, we can hear you. If you could, we might not be able to see your presentation, but we can put it up afterwards on the web. Dr. George.
Okay, I will put it on later. Just like of Zoom, that Ministry of Health as a sector this time around
Dr. George, I think we might be missing your voice. We can see your slides, but we might miss your voice, unfortunately, in doing so. I think we've lost Dr. George Opentio, unfortunately.
Very
What I will do.
disappointing.
Oh, thank you, Dr. George. We might have to go without the slides, otherwise we might lose you again, I think, but I can put the slides up on the web afterwards for you.
I don't know what I should do for you now.
I think if you could just speak to your speak to the slides, and we'll make sure the slides go up afterwards. That might give the most impact. Thank you.
Okay, I'll run through quickly. We all know that the universal health coverage is talking about leaving nobody behind, which is actually a new global commitment for all nations to strive and achieve the SDGs. Of course, we know the Astana Convention of 2018, which has presented us an opportunity as Uganda, together, of course, with all other nations globally, to review and take stock of the gains made, in addition to the shortcomings made in the 40 years journey to institutionalize primary care post-Almata. Now, the Astana Declaration, as you know, has ushered us all from the Almata towards the universal health coverage. But for us as Uganda, the government of Uganda remains really committed, not just to meeting only the SDG, but also delivering the universal health coverage to all our people. Here we say health for all, by all, using the established community structures and systems. And so the government of Uganda, through the Ministry of Health, intends to make good on its commitment through empowering individuals and communities, in addition to aligning stakeholder support to national policies, strategies, and plans to support community-based healthcare system. Now, the community health system in Uganda, as you may know, it is strongly linked to the overall formal health systems. At the national level, formal structures are in place to govern, oversee, and supervise community health workforce across the country. As Uganda health systems is decentralized, implementation and management of community health services are conducted at district and lower, that is the health sub-district and sub-county, parish, and village levels. Each district has a health department, which has the mandate to plan and implement health services in their respective districts. We have community health workers, the ones we want to refer to as the village health teams and other critical community resource persons. They do exist, including but not limited to health assistants, in our formal structures, the community health development officers, like linkage facilitators, if you are talking about TB, the case managers, if you are talking about HIV, and many others. There are also private non-profit health services and other community groups, for example, local council leaders, parish chiefs, religious leaders, teachers, traditional birth assistants, mother peer groups, Girl Guides, Boy Scouts. Now, these communities in Uganda are currently playing a passive role in community health services. They are, for most part, on the expectant side, acting solely as consumers instead of also demanding quality services from from health workers and community workers. Now, Ministry of Health through community health departments continues to drive the Uganda community health system strengthening program agenda. As I speak, community health national priorities have been drafted, and there are 6 key priority areas which I will maybe state for you. And there are also opportunities for integration at various levels. And these levels refer to integration of community health with the broader health systems, also integration across programs, partners, and disease areas in community health system, but above all this integration across sectors and agencies in the spirit of multi-sectoral engagement and collaboration. Just to tell you briefly, what are these 6 key priority areas for community health services that anchors itself on the community-based service delivery platform? We have identified 6, one of which is we want to come up with a comprehensive, evidence-based and costed community health strategy. And this is ongoing because of what we saw coming out as a result of this pandemic, to strengthen also to strengthen community health leadership, governance, and multi-sector collaboration. For we have seen that this is lacking, given that community health space is a very wide space. We also want to strengthen and sustain investments in supervision and motivation particularly of the community health workers. Number 4, we want to strengthen and improve the community health supply chain for critical commodities and supplies. We all know where COVID has driven us. COVID for us has become a community disease, and we need those commodities which will help them go through the public health measures as our enforcement law states. 5 is to invest in appropriate technology, especially looking at digitalizing the community health tools, especially now that we are going into the digital world, and we want to invest in what we call active community engagement. And I will take you through another presentation here. Let me first get out of this slide, and I give you another screen to show you what it is that this government is committed to do through Ministry of Health. I've talked about active engagement of the community, and our community basically, under decentralized response, falls squarely within the Ministry of Local Government. And there has been engagement between these ministries, departments, and agencies, how we can now deliver services in comprehensive manner to our population who live in the rural communities. And this is a statement which we have decided to share widely for people to know how our commitments will be achieved. And this statement by the Minister of Local Government on the community engagement strategy was delivered on the 7th of this month. That is 2 days ago. After a serious the national as well as the strategy of various and urban to give position of the Ministry of Local Government and the government role. We expect to the contingent and to support provided this second of COVID-19. Now, this strategy we are talking about as community engagement strategy is a strategy which was developed by Ministry of Health and presented to the National Task Force, which is looking at empowering the community to take health as a duty and as a right. And it goes to say, I thank most sincerely Professor Maswa Francis, and this is a household name in Uganda. And within the fraternity of primary health care, you must have heard him saying, health is made at home and only repaired in facilities or hospitals when they break down. And so this statement goes to thank Professor Omaswa and his team for giving this strategy its philosophy and justification, and for piloting it successfully in a number of districts. The community engagement strategy was approved by Cabinet as part and parcel of the national strategy to fight COVID, and we should all give it our full support. It goes to say, at our swearing in as ministers last month, and we have just sworn in new government, which is going to take us for another 5 years. I think they are not even 1 month old in office. So he goes on to say, at our swearing in as ministers last month, His Excellency, the President, gave us 5 key principles to follow in our work. These are cohesion, no corruption, integration, patriotism, and service delivery. His Excellency, the President, has been at the helm of this pandemic to give it all his energy to fight this COVID. To me, these are also fundamental to the community engagement strategy. The overall goal of this strategy is to empower the communities to fight COVID-19 and its negative social, economic, and health consequences in our respective localities. Specifically, we are aiming at achieving the following. Number 1, reduce transmission and eventually stop the spread of the virus in the communities. Number 2 is to increase awareness, adoption, and observance of the SOPs and mobilize residents to go for testing and vaccination in the gazetted places. 3, increase surveillance and monitoring of possible infection at household levels. 4, enhance the capacity of the local authority task forces to evaluate affected persons, to evacuate the affected persons to the health centers and other designated areas in a timely and coordinated manner. Support the home-based care of the affected persons, including psychosocial, as to reduce on caseloads in our health facilities. 6, sensitize the communities on measures to strengthen immunity and the capacity of the body to resist and fight the virus through appropriate nutrition, physical exercise, mindset, and social behavior change. And lastly, to provide the necessary, timely, and accurate data and information on the pandemic by maintaining village registers and providing reports of the local authorities for onward submission to the Ministry of Health and National Task Force. The Ministry of Local Government was tasked by His Excellency the President to provide the necessary support and facilitation to the regional and district task forces and to revitalize the local government structures in all his addresses. His Excellency the President has stressed the importance of the community in taking on the challenge, especially to ensure prevention, early detection, surveillance, evacuation, giving correct information to the public, and enforcement of SOPs. His Excellency also directed that the village health teams be facilitated so that they are able to support the village committees and help to improve primary care, nutrition, sanitation, and hygiene at community level through routine visits to homes and liaison with the health centers threes. This is the first time the president is committing that the village health teams be paid. According, Cabinet, on the advice of the National Task Force, has approved the supplementary budget for the fight against COVID by the different agencies, which will later be presented to Parliament in line with the Public Finance Management Act between today 7th and tomorrow 8th July. That was yesterday, 2021. And they say we shall release the following finances to the task forces through the local government accounting officers. In this respect, each district and city will get 150 million. That is every quarter. Each municipality will get 100 million shillings. Each village health team, that is one member of that village health team, will get 300,000 Uganda shillings starting this quarter of our financial year, starting July, September. And each village committee where this village health member comes from will be receiving 100,000 for that quarter. So every quarter that money will be disbursed to support the village health committee and the village health team. Now the permanent secretary minister of local government shall issue guidelines to the accounting officers on management and accountability of funds. Provision has been made for the meetings of the task force, referrals to the hospitals, facilitating the lower local government structures, that is the sub-county, the town councils and divisions, as well as maintenance of ambulances and other vehicles provided by private individuals for this exercise. Finally, I wish to reiterate the commitment of government to roll out the community engagement strategy. It is a unique feature of Uganda's fight against the pandemic. My hope is that the community engagement strategy will remain, again I repeat, my hope is that the community engagement will remain a basic ingredient of Uganda's health care system. We shall continue to refine this system and to give it more clarity with respect to the following aspects of the decentralized response to COVID. 1, monitoring and evaluation framework and documentation. 2, data collection, management, and reporting system. 3, institutional linkages between the village health teams and local government health structures at the various levels. 4, sustainability of the community engagement strategy, in particular, provisions of PPEs and other logistics for the village health team, village task forces, parish task forces, sub-county, town, division task forces, and their roles now and beyond COVID-19. That is how far we are looking, going beyond COVID and post-COVID. And he goes ahead to say, together, we shall defeat COVID and provide a healthy environment and a better country for us all to live on. And he signs as Honorable Minister Raphael Magezi, Minister of Local Government. And that was on the 7th, 2 days ago. And when I was asked to make a presentation, what are we doing as Minister of Health to improve the life of the rural people? And we know 90% of our rural population lives in the rural community under local government. And that's where we are taking the fight. And we have prompted local government to rise up to the occasion. We gave local government our community engagement strategy, and it is premised on this community engagement strategy that local government has come up with this position, and government picked it up and said, this is the way to go if we are to improve the life of our rural population. I submit, thank you. That is from me, Dr. Upento George. Thank you, over.
Thank you very much.
Thank you very much, Dr. George. And I hand back to Dr. Bruce.
Thanks. Thanks very much to Dr. George for that, and thanks very much, Jane. I just want to share a couple of final slides. Thanks. I do realise we've gone over a little bit, and so I'll quickly go through these just to give you a bit of an idea and a taste of where we're going from here. So I'll just bring up the slideshow. So I think the first thing is to thank you all for joining us tonight. It's right across the globe. So we've got people from North America right through to New Zealand. I know it's getting quite late in New Zealand. They're ahead of us here, and it's 11 o'clock here, and still very early in the morning in the United States. Just go down. The key thing, I think, is to just highlight what we are doing over the next few months. We're going to be concentrating very much on African exemplars over the next few months, having webinars as part of the conference to really highlight the African part of the globe. Then there'll be the WHO webinars. We've got the Afro PHC feature on rural health, primary health care, and we've got some other partners who we're still working with to look at how they'd like to contribute. As Theodora said, the topics are around particularly universal health coverage, but policy and rural proofing, Indigenous health, gender equity, innovations, the agricultural sector, information systems, and women's role. The first of our WHO webinars, as Theodora said, is next Thursday, and it's the same time as this one has been. So that's 1100 UTC or 1300 CET and 1400 Ugandan time. Following that, we'll be doing the next topic is around Indigenous health, and on the Friday, the 30th of July, we'll be talking about Indigenous rural health in Africa. I think we often think of Indigenous groups in developed countries, but they're equally important in lower and middle income countries, and I think Theodora very amply talked about that. So we've got that, and then the seminar that Theodora mentioned about community engagement, and we've got a lovely panel there across India, Brazil, United States, Canada, Mali, Chile, and Australia to try and get those different viewpoints. Then following on there, we've got African women in rural health, and that's on Friday, the 8th of October. These are all at 11 o'clock UTC. And we'll be looking at the situation for women in rural health, and not only their sometimes difficult circumstances, but the power and strength that they bring into rural health. And we've seen that in many communities, the benefit of strong women being able to assert for their communities. And then on Rural Women's Day, on the 15th of October, there'll be another WHO seminar on policies to develop, attract, recruit and retain health workers in rural and remote, and promote gender equality for rural women through health workforce policies. So just a bit of a taste of what's coming up in the next few months. We go right through until February. We've, as we've described, these are long conferences with a smattering of opportunities for you from week to week. And we're just finalising some of that program, and we'll put it on ruralwonca.org. So the closing ceremony will be in February next year, and that's an ideal time for us to have worked through a lot of these things and come to hopefully some more help for universal health coverage in Africa. You can see the very grey area there in Africa about universal health coverage index. And then we want to join that up with the Wonca 19th World Rural Health Conference, which will be in Ireland, hopefully face to face on the 17th to 22nd of June 2022. So we have gone over time. I do apologise for that, and but it has been lovely having you on. And we do look forward to catching up with you next Thursday at the very first of our WHO webinars, which has its own login, which I've sent out on the email. But certainly, if you have any issues, you can leave a message on ruralwonca.org. There is an email there to leave a message, which will come to me, or many of you will know the Wonca Working Party Google group. So in my case, it's good night. In the case of Uganda, it's good afternoon. So I might just ask Innocent to just say a final farewell. Thanks, Innocent.
Just to say a special thank you to everyone who attended, who spared the time to attend this opening ceremony. It has surely given us the momentum. So it has surely given us the momentum, and we are really looking forward to active participation in the forthcoming webinars. We are really trying to spread the activities of this 18th Wonca Rural Health Conference across several months, particularly to maintain cohesion and also minimize the social distance between us. And we are really hopeful that we are going to share a lot, talk and network online, and see how best we can provide the better health services for the rural populations, which is actually a significant proportion of the global population. Thank you very much, and looking forward to seeing you in the next activities of this conference. Thank you very much.
Thank you, Innocent. Night, night.
Thank you.